I would like to extend my heartfelt invitation to our chairpersons. Please come forward and join us here on stage. We have Dr. R.R. Rai, Dr. Manisha Devedi, Dr. Brajesh Sri Sharma, and Dr. Jasmohan Bajaj. I welcome you deeply on stage. We have doctors with compassionate hearts and healing hands, and let us give them a turn to invite the speakers. Over to you, chairpersons.
Good afternoon. This is a case-based panel discussion on the prevention and management of acute on chronic liver failure, an entity which we all encounter frequently and a bit difficult to manage and treat. The moderator, we are privileged to have Dr. Rajiv Jalan as the moderator, and the panelists are Dr. Ashok Chaudhary, Naren Chaudhary, Naveen Ganju, Saira Matluri, Shweta Singh, and Sonal Asthana. Only two of them.
Only two panelists. I think. Where the rest?
Three. Yes, Dr. Jalan, please.
Okay, well, first, thank you very much for this very kind invitation, Ajay, INASL, and Patrick, who's organizing this session. So it is really a great privilege for me to share this case with you, which is a pretty complex one, which I was involved in the care of a few years ago. And I thought that I will share this with you to go through it and see what you think today. Okay, so here are my disclosures. Probably nothing is relevant to this particular case. So this is a patient with primary sclerosing cholangitis. He's a pediatrician in the final year of his training. He was diagnosed with PSC about 12 years ago. He has both intra and extrahepatic biliary strictures, but there is no endoscopic option for stenting or anything like this. He's been very well for the last few years, up until this last 1 year, where he has 3 episodes of cholangitis. And despite that, he presents in the clinic with stable liver function tests, and when he's last seen, his bilirubin is 2.3, his INR is 1.2, and creatinine is normal with a MELD of 11. He has esophageal varices grade 1, but is receiving carvedilol. There's no ascites or hepatic encephalopathy. He also has pancolonic disease from his ulcerative colitis, which has been his major problem. And this has been troublesome despite biologics. So he's admitted to the hospital with a pancolectomy, and developed an ileal pouch. So this is my first question to my panelists. So what do you think is the risk of his decompensation, and what can you do to prevent it? So maybe Dr. Gunju, maybe.
Yeah, any cirrhotic, as we know that these PSC patients are not truly cirrhotics. They are different, but in any case, because the bilirubin is 2 and has previous cholangitis, there will be some fibrosis. The risk of decompensation is still a decent one. And what can we prevent is to manage as much as possible and make sure that the other organs are very well managed peri-op, and whatever we can do regarding that.
So I think, this is a typical case, I think, of, potentially a really high-risk situation where you have somebody with a MELD of 11 and a PSC undergoing a colectomy. And these are data from a paper which I think has been replicated 2 or 3 times now, which show that the risk of mortality of this patient from a liver-related complication, liver-related death, is really about 15% in 30 days. And its odds ratio of dying is about 4.9 times somebody without colorectal disease. So it is really a little bit surprising for me to see these very high numbers, but of course I think it behoves us that, one of the central issues that we need to think about here is that the risk of potential infection following a complication. And just to sort of come back to this, one of the main issues here was really the previous episodes of cholangitis that this patient has had, and therefore he may well be harboring multi-drug resistant organisms. So I'm not sure what more you would do except to be careful with very careful monitoring and understanding of the microbiological environment that this patient was in. In any case, he was discharged from the hospital within 6 days and returned to work in a limited capacity after 11 days. But what was really dramatic was that nearly 2 weeks on, after the surgery, he developed episodes of nausea and vomiting, developed a pyrexia. He was started on treatment with coamoxiclav by his GP in consultation with his surgical team. And interestingly, within another week or so, he now presents to the hospital with rigors and high fevers, has right upper quadrant pain, and is unwell for about 7 days. His abdomen is soft, non-tender, with no localizing signs, but his now bilirubin is shot up to 8. His INR is 2.1. His creatinine has gone up to 1.8. Has no hepatic encephalopathy. His circulation and respiration are normal. His white cell count is now 17, with a CRP of 65, a procal of 3.4. So his sepsis screen is sent, and he's now been managed with excessive amounts of fluids. So he undergoes a CT abdomen, which doesn't show any collections, no leaks, undergoes an MRCP, which shows unchanged appearances of the biliary tree. So maybe I hand this to Ashok. So what do you think is going on here? Does he have an ACLF? Should he be managed in an intensive care unit or the ward? What are his risks? And what are we going to do?
He is fit into the SCLF definition in ways he has got an acute insult, that is surgery, likely one infection also recently new onset, and he develops his worsening of bilirubin as well as INR and AKI. So it's fitting to an SCLF. Then ICU, if you think of our Indian scenario, we'll manage in the ward because he's hemodynamically stable, sensorum is okay, lactate is decent. So I'll manage in the ward. Obviously, we'll give antibiotics, hydration, albumin, so things. And risk for him is the infection we have to see, the background of PSC cholangitis, cirrhotic liver, and decompensation. And if the infection is cholangitis in a PSC patient, it is a little bit more troublesome because it is intrahepatic infection, take more time rather than any other site of infections. So definitely we need antibiotics, then monitoring dynamically for 4 to 7 days how his respiratory therapies. And right now I need stabilization, prevention of organ failures, antibiotics and nutrition. And hopefully I'll see by day 7 to whether he is responding, then we can manage, or else I have to think of transplant. But more of I need a dynamicity at day 7 to think of the transplant to be evaluated or no.
Well, thank you, Ashok. So maybe I can come to Professor Bajaj, our chairperson. Would you do anything different in the US, Jazz?
In the background of biologics, in this person who's been having a lot of immunosuppression already, my money is still on like infection unless proven otherwise, and either caused or exacerbated by the surgery, like you correctly pointed out. We use a separate score called the vocal pen score to actually differentiate. It's available online, and it's not specifically for colorectal surgery, but it actually gives you a intra-abdominal surgery as well. And it is very useful. And of course, in this person, you have to do the surgery. This person is miserable quality of life, and he's a pediatrician. He can make his own decisions. With the shared decision making, you came to this conclusion. But with this person, I would start with a very broader spectrum antibiotic and then wait for the cultures if possible. And of course, I'm sure the surgeons are involved deeply, right, at this stage,
Yeah, of course.
if not earlier, and go deeper if they want to do an ultrasound, etc., as well, to make sure that there's no collection that's hidden elsewhere. So my money really still is on the infection. So as far as the transplant thing is concerned, given this such a temporal relationship with the surgery, there's still hope that this is reversible and something that is peri-surgical. So I think the transplant is in the back of our mind still, but I don't think that would be our leading thing at this point. But broader spectrum and then going further as the cultures come.
No, thank you. So my question specifically is with respect to intensive care support for him at this stage. So this is obviously the big discussion that we have with ICU people, that is not encephalopathic, not really requiring organ support. But we know he's deteriorated very quickly over a short period of time. Would you get him to the ICU, monitor him, and
we would certainly, so now we would certainly have the ICU team be aware of him, and maybe if they're feeling generous, they will take him to the step down unit, where we can actually monitor this person's vitals a little bit more, given that this person has IBD also and is exposed. So if we sell it the right way, I think we'll get a little more traction as opposed to someone who would have just had cirrhosis without the IBD along with it. So I think we may get a little more. Well, you're right, we should involve them right now. They may still say no, but at least this person is on their radar in case things start heading the wrong way. And clearly we need to monitor not only the vitals, but also the kidney function and the lactate in this person very, very quickly.
thank you. I just wonder, perhaps a show of hands, as to who would move him to the ICU at this stage, or we are happy with the ward. So urine output is still okay. So about 5-10% will move him to ICU. Anyway, so what we use is the CLIF criteria to diagnose ACLF. And as you can see here, it doesn't actually fulfill any of these criteria here that diagnoses ACLF. And so therefore, we put him really on the bucket of what we call pre-ACLF. And in this situation, what one would use is the CLIF AD score in order to determine the risk of mortality. But for all intents and purposes, he has a CLIF AD score of 63, which is calculated using INR, creatinine, sodium, white cell count, and age. And this is sort of mentioned, this is happening live in his notes every day. So his CLIF AD is 63. His risk of mortality is calculated as 28% at three months. And so basically what we do is an aggressive treatment, as has already been suggested, and move him to the ICU and organ support as required. And just to put this whole idea into concept, the whole idea of pre-ACLF in this context was defined in relation to the PREDICT study, which was able to identify patients that are likely to progress to ACLF and a high risk of death. As you can see, the pre-ACLF population probably has an intermediate risk of death between 2 and 3 organ failures. And just to put this into context, here is our patient with an infection which brings him to the hospital. He has no ACLF but pre-ACLF, and so therefore he's obviously at very high risk of developing ACLF. So day 23 to 24, he's now moved to the ICU. He has a central venous catheter, a urinary catheter, aggressive fluid resuscitation, received some albumin, and an NG tube to start feeding because he's not eating anything. And at this point, his bilirubin is up to 14. His INR is up to 2.4. Platelets go down to 170. His creatinine is 2.4, and the urine output is now down to 30 mils an hour. He's got grade 1 to 2 hepatic encephalopathy, probably more like grade 1. His circulation is well maintained, but now his lactate is 2.8. His saturations are starting, is pretty much normal, but his white cell count is elevated. CRP and procal both continue to go up a little bit. So we start to grow Klebsiella and Enterobacter in his blood, which is sensitive to meropenem. He's already receiving meropenem, teicoplanin, and teicoplanin is started on amphotericin empirically because of this deterioration. So my question to our next panelist is, has he now developed ACLF? What are his risks and chances of recovering?
So yes, there is progressive worsening of creatinine, bilirubin, HE, although doesn't qualifying organ failure yet, but yes, this is suggestive of ACLF. He is worsening at present. He is not improving despite 2 days in ICU, and this patient should be kept on liver transplant list. He may recover, but significant risk of worsening and liver transplantation. Yes.
So do you worry about untreated bacterial infection here? He's got uncontrolled infection with
Yes.
Klebsiella.
So controlled infections can be taken, uncontrolled no.
So he's actively septicemic, right?
Yeah.
So he's
So-
already, if I may add here, it's me here from the panel, from the panel.
Yeah.
So he's already receiving the sensitive antibiotic, but he's still continuing to worsen, isn't it, on that?
Kindly speak into the mic, please.
Sorry, I can't hear you.
So he's receiving the sensitive antibiotic according to what we saw, but he continues to worsen
Yeah.
on it.
Yes.
So that is one worrying thing. Maybe we are developing some resistance here. And with the creatinine of 2.4, would amphotericin be a good choice rather than echinocandins? Because you are again trying to save the kidneys here.
I guess I'm not sure what the other panelist thinks, but obviously he would now be on a CVVH. He'll be on organ support, so the kidney is already gone. Sonu?
Yeah, I think his liver is clearly going down, but he has active infection. At this point, I'd be loath to put him on an active transplant waiting list unless we have evidence that the infection is turned around. So what we should be looking for aggressively is untreated sources of infection, foci that are potentially drainable, because that would probably make a difference. The interesting thing here in this scenario is that the heart rate hasn't gone up at all.
Yeah.
So that's something that perhaps is a little off as compared to the other things that we are seeing here. I agree that at this point it's important to treat the infection aggressively and worry about the kidneys later.
So are you worried about the heart rate because you think that he's now got some sort of reduced cardiac response to his injury and his infection?
Yes, because generally speaking that we would expect some degree of cytokine surge, active infection. We would expect a reasonable amount of tachycardia, which would sort of be in line with the rest of the clinical picture here. So certainly I would probably look a little bit deeper into his cardiac function right now.
Well, thank you. So just to put this into context, so he is an athlete.
Okay.
He runs 5 marathons a year. And so his heart rate, I guess, resting heart rate must be very low. And it's very interesting that this chap was running marathons in between his cholangitic episodes. So,
Okay. In that case, probably not.
no, it's a great point.
I think it's really smart for us to, it's me, to consider antifungals in this person.
Yeah.
But again, I think with this biologics that I seem to maybe atypical viral infections in as well, because clearly the meropenem, that he's not responding to that. So I think maybe this is the time to bring in our ID people to look at zebras with this things that are just not responding. Clearly he has Klebsiella, but there's something else also going on. So antifungals are really clearly the way to go in this person.
Thank you. So I think the good point here is that, we need to look for a viral infection. And there are increasing evidence, and you might have seen some in the literature, suggesting that CMV reactivation is a very common problem in patients with advanced ACLF. and is probably really relevant here because it may well be a contraindication to liver transplantation. So thank you for that. I'm not able to confirm or deny whether we measured it or not, but so he's obviously on multi-organ support. And the big question here, and maybe this is a question for Ashok, so what is your criteria for starting CVVH in patients such as this? Maybe, when we brought him to the ICU, his creatinine was 1.8, 1.9. Would you start CVVH early, or would you wait for full-blown renal failure before starting CVVH?
No, like this patient who is acutely worsening, I should go little early. And now I think he's a good candidate because his hemodynamic parameters still preserved and metabolic acidosis just starting. So now he's a good candidate to go for. So I think we also do routinely this type of patients we go for this, sometimes with the filters.
So, of course, he was already in a liver transplantation unit, but the point has already been made that if he was not in a transplant unit, then you should obviously start to have conversations to try and move him to the liver transplantation unit in the last place. Any other comments, chairpersons?
I think maybe the other thing we hope that obviously he will get to the point where we can transplant him, but now is also the time to involve his family members, especially since he's encephalopathic, and of course involve him to the extent.
He's not yet HE.
Of course, he's HE. So basically, see in case is too sick for liver transplant, and see what his wishes are, etc. I mean, we're hoping for the best. We're hoping things recover, but now is the time, rather than waiting till all the organs have failed, to start having those goals of care discussion as well.
Okay, so obviously, is there still chances of reversibility with his own organ, with his own liver? So these are data based on the canonic study. And what you can see here is he's obviously got ACLF3, but there's still, about 12 to 15% chance that he might recover from his ACLF. But of course, that's not a chance you might want to take with him. So is it possible to determine his risk of death? And this is done using what's called the CLIF-C ACLF score, which you can calculate, is based around the age, CLIF organ failure score and a white cell count. And it's a dynamic score which is from 0 to 100, which gives you a risk of death at 28 days and 90 days. And as you can see here, his ACLF score was 49, which places him at a risk of mortality of 35% at 90 days. So what you can start to have is this sort of numerical understanding of where your patient is, which allows you to have these discussions with the family and the rest of the team that, yeah, he is getting to a point that we should be thinking about liver transplantation. And just to put this story into context, it is just important to think that, if his score gets to 64, that is giving him 85, 90% risk of death. And this is a futility score that you can define in case he was not a candidate for liver transplantation. And it can help you start making decisions as to whether or not, what are his chances of survival without a liver transplant. So, are there anything else available to us? And so, he's obviously got a little bit of infection on board. So is GCSF and a solution for him? Are there any extracorporeal strategies? Would you use plasma exchange, for instance? Is there anything else out there? So maybe, GCSF story comes from RBS. So Ashok, what do you think?
No, I think GCSF is not for such a sick patient and is acutely worsening now. Second, extracorporeal support we thought of, but because fever is ongoing, active sepsis is concerned, a little bit hesitant. So we'll continue with therapies and CVVS as a support, and we'll hope.
Thank you. So this is exactly what has been shown in the literature. So this is the results of the GRAFT study, very large study in Europe of GCSF versus standard of care alone. And as you can see, there was no significant difference in survival. So in advanced ACLF, we don't think that there is a role for GCSF in the treatment of this patient population. We completely agree. And these are really data from the MARS studies, and this is a relief trial, again showing no significant advantage in terms of survival between the control group and the treated group. And here is the data from ELAD, which is extracorporeal liver assist device using hepatocytes. Again, no significant difference in outcomes. So therefore, what else is there? And these are the data that we generated recently using a device which exchanges albumin, takes out DAMPs and PAMPs, and it helps resolve ACLF faster than the control group. So, and again, this is in patients with ACLF grades 1 to 3, but obviously it's not available in clinical practice. So hopefully watch this space moving forward. So that's sort of the next phase. What about plasma exchange? Is there anybody who's a plasma exchange fan? Anybody plasma exchange in the audience at this stage? Any show of hands? There's one there. Anybody else?
Its role is still debatable, plasma exchange.
Would you use it?
We use not in active infection or hypertension or patients on dialysis, but otherwise stable patients with liver failure, high bilirubin, high INR, who say that it will take maybe 20 days, 30 days to arrange donor and money, then we do Plex. It helps in stabilizing.
Exactly.
I was the leading enroller for Apache, so
Yes.
but we don't know the results yet.
Right.
Based on whether that is positive or not, I think that would be something. But till then, there's no good randomized control evidence. So unfortunately, we are kind of on the path. It's curious. Did you repeat the CAT scan at this stage to see if any collections?
Yes,
had
he's
developed?
had two others, sorry. In the
I'm
middle.
sorry?
He's had two other CTs
Oh my God. Okay.
looking for infections. So I think I completely agree. The Apache trial is a massive trial which is being performed globally. I think Europe and the US. The study was closed prematurely after inclusion of 271 patients. So not sure it'll give a conclusive answer one way or another. But so it's very interesting that you're not using plasma exchange in this situation. And this has already been discussed here, that we need to think about liver transplantation in this situation. But while we are thinking about it, he deteriorates rapidly, now develops grade 3 to 4 hepatic encephalopathy, has increasing requirement for inotropes, is obviously established on CRRT. His bilirubin is now 22. His INR is 2.8. Fibrinogen is down to 1, and platelets are 78. He is oligoanuric on CRRT. He's now developed grade 3 to 4 encephalopathy with high ammonia, and CT head shows cerebral edema. He's on mechanical ventilation. His MAP is now down. He's requiring 0.4 mics per kilogram per minute of noradrenaline. Lactate is 4. Respiration is still okay. The lungs are fine. And his inflammatory markers show a white cell count of 18. So it's pretty much static from where we are. We're still growing, Klebsiella. Amikacin is added, and a shot of gentamicin. Others are continuing. So where we are today is he's got 5 organ failures, 3 requiring support, Cliff ACLF score of 64, and 28-day mortality of greater than 85. So Sonal, you're going to transplant him.
I think that how many days of antibiotics has he received already?
Sorry, I don't get that.
How many days of antibiotics has he received
Oh,
already?
so he's been receiving antibiotics for the last 2-3 weeks, 2.5 weeks.
3 weeks. So if he's received more than 7 days of a sensitive antibiotic, then I think we are probably on safe ground to transplant him. The only condition where I would not transplant him is if he had a respiratory failure at this point. So at this point, if we think that we have treated the infection adequately based on our treatment, I mean, the only red flag obviously is the positive culture, but that would probably be grounds for a high-risk transplant. The only place where I would not consider it at all would be if he had respiratory failure on top of this.
So let me ask the guys, let's look at this one again. So 5 organ failures with some infection on board. So how many would actually transplant him?
So would we be asking the surgeons to take a look inside to see if there's a perforation or is there something that is not detectable by CAT scan?
Yeah, I
I'm
mean,
sorry to be anecdotal. We
he
had a
would,
patient like this who just kept, no, while you're doing a transplant or whatever you want to. So this,
no, he won't survive on those guys.
his peritoneum would not clear. We had a patient. The surgeon, we rejected him for transplant, went to another center, went there was actually a hole in his colon that none of these things could discuss. He spent 1 year post transplant in the hospital after immunosuppression. They finally figured out where that hole was in his colon, and that was a patient who actually did not have a colonic surgery to start with. My fear is that this person still going Klebsiella enteric bacterium somewhere from some place that needs something more deeper than a CAT scan. And this stage, his kidneys are already gone. So you can give him as many, things as you want to actually figure out where the source is.
So we have surgeons on the table, so.
Absolutely, source control, we completely agree that we need to take care of that. The problem is that if you do an exploratory laparotomy for this patient, you will not get him off the table. The only way he gets off the table is if he comes in with a new liver. So agreed that we should image him as best as we can with a CT, perhaps a PET, if we think there's a localized source. And source control is probably the single biggest thing we can do. But if we do not find a source, we have to assume that it is being driven by the liver and an active infection. If we have managed the active infection to the best of our ability, and like I said, with the respiratory being the caveat, a high-risk transplant is probably what we can consider.
So do we believe this is a
Sonal, one more
biliary
thing.
source?
Sorry?
Do we believe this could be a biliary source in someone
It's
who has
possibly,
not
yeah.
had
That's what we
cholangitis
think it
for
is.
a while?
So he has
We think
multiple
it's biliary.
intrahepatic biliary strictures. So, I mean, the assumption is that he's got ongoing cholangitis, which is...
So we think it's from the bile duct.
Yeah, but I agree with the point about the source control. I think that we do need to look
The
long at
source
that.
is the liver, right?
Yeah, if it's the liver, then we'll have to change it.
So how many people would list him for a transplant? Anybody else? Any show of hands? So only 3 people. And Sonal, 2. Any of the panelists?
I think PSC is one of those conditions because when you know the source is the liver itself, and you might not be able to get a negative culture ever. It's like one of the outliers.
And
that
so one
situation.
more thing, Dr. Sonal, he's in cerebral edema. You're okay with this? Cerebral edema is there.
I mean, I think cause and consequence are two things that we really need to think about here. The only caveat for me, like the only saving grace in this entire thing is that his FiO2 is 0.3, and we still have working lungs. Because if we were doing this in the presence of respiratory failure, my answer would be different.
Okay, thank you. So look, again, this is exactly the discussion we were having. So most of our audience doesn't think that we should transplant him. There were 1 or 2 or 3 of us that were very seriously vested into this young doctor. So there was a lot of to and fro. But anyway, before we go there, just to sort of discuss with the audience what is the evidence that transplanting these patients can work. And this is really the first work of Vinay Sundaram, which showed very nicely that these patients can benefit from a transplant. As you can see, post-transplant risk of death is very low. And this is now the data from the CHANCE study, nearly 1,000 patients in this trial. As you can see, patients with ACLF grade 3 do very well, but we're talking about a different kettle of fish here. I'll skip these, it's in the interest of time. So the serious question here for us is to determine what his risk of dying with a liver transplant is. And really it's very, very, very difficult because there is not a single factor that determines the risk of death. It's an accumulation of several factors. And these are the factors on this list that have been shown to be independent predictors of mortality post-transplantation. And as you can see from our particular patient, he is requiring high vasopressors, but is only on a single vasopressor. His lactate is 4, which is an important component part of the TAM score. But again, he doesn't fit anything here. He's got poorly controlled infection, but that is, we think, one of the biggest contraindications in this situation. Is anything that can help you in this situation? This is a score called the SALT M score, named after Vinay Sundaram. And this is really a conglomeration of 5 factors. And Most of these have already been brought up already. So if patient is old, or if they've got a high BMI, they're requiring 2 presses, or they've got respiratory failure, or they've got comorbidities such as diabetes, are independent predictors of risk of death. And for this particular patient, you can calculate this. And of course, this doesn't include infection, which is the difficult one here. His 1 year post transplant mortality is only 21% according to this model score. And we use this in order to justify transplantation. How does this work in clinical practice? As you can see here, it is probably the best predictor of post-transplant mortality in this patient population. And if we get him through the first year, then he should have fantastic survival. And these are data about long-term outcomes of liver transplantation in this patient population. Before I go and tell you as to what happened to Dr. AV, what about living donor transplantation? So cadaveric, all the data is for cadaveric. Do you worry about living donor? Yes.
So I mean, it's an interesting question because it's one that we face on a daily basis. Your sort of ethical conundrums are different for a DDLT versus an LDLT graft, and certainly the principle of equity is probably not as you have to balance it out against the donor mortality. Most Indian centers currently are able to perform living donor transplants with a relatively low mortality for a well-selected donor. So we have been pushing a lot more LDLT for ACLF, and the East is where the data is coming from. So in our view, if the patient is suitable for a transplant, we would consider him for an LDLT.
Even in this critical situation?
So the only absolute contraindication in this situation, I mean, there is some Indian data to back this up, is ACLF with a strong respiratory component. Right. So that is probably our single absolute contraindication here.
So we at our center, non-oliguric kidney failure we will take, but significant vasopressors and respiratory failure we will not take for LDLT.
Brilliant. Okay, just to sort of come back to Dr. AV. So he underwent a successful liver transplant with a cadaveric organ. Very stormy post-operative period with prolonged ICU stay. He was probably there for about 6-7 weeks. Prolonged rehabilitation. He took a year to get back to work. And it's pretty dramatic that within a year of return, he completed his training and has now got a consultant post, is back to work. And if anybody wants to hear the story of him and his wife, both of you are doctors. We brought him to an INASL studio where we discussed this. So it's an interesting story. So just to sort of conclude, therefore, liver transplant does save the life of patients with severe ACLF. So if you're thinking about it, get these patients to a transplant. And we've discussed the rest of it, but just to say that Chance is finished now, and we'll have huge amounts of data which will put many of the unanswered questions into clinical perspective. We've got nearly 70 or 80 patients with living donor transplantation in the series, so we should be able to answer that question as well. So with that, I'll just say do we have time for discussion, do you think, or are we
We
done?
have 8 minutes.
Yeah. 8 minutes. So yeah, any questions?
You had already involved a lot. That's why we didn't stop you before.
Oh,
so
perfect.
it's okay. So
It is
any other
said-
questions from people in the
Yes,
audience?
please.
Very
Yes.
short questions.
One comment.
Very short
A very
questions.
short
Dr.
question
Kedia.
that when the first time he had fever and he went to his GP who gave him coabaxiclav, why wasn't a white cell count or a cultures done? Because he's had major surgery done. We know he's got PSC. So I think at that point of time, it was easier to diagnose what was happening, what was the bacteria growing. I think we missed that window of opportunity. So that probably he would not have become that sick.
Completely agree.
It is said that MELD sodium is not a good indicator for transplant in these patients. You have
No.
to consider the grade of ACLF and grade 3 or beyond.
No, so the point I was trying to make, which I don't have time to discuss the data today, is that MELD sodium does not identify patients at risk of dying on the current waiting list. So in the UK, for instance, these patients have priority for liver transplantation, where in ACLF grade 3 patients, even if they got a MELD of 25, will get an organ within 48, 72 hours. And this is now moving forward. So yeah,
Mike
Sameer.
2. So Rajiv, do you have die alive for such patients for clinical use, or it is still in research?
So it is still for research, but it's just about to receive its CE mark, where we can use it off-label in individual cases. So we're just waiting for the certificate before we can start using it in clinical practice.
Great case. I had two questions. I noticed that initially amphotericin was used as an empiric antifungal, and later you had used amikacin for the Klebsiella. Generally, in cirrhotics, especially when the ampho was used, the creatinine was 2.3. So would you use that? Because it was empiric. Would you choose to use another broad spectrum antifungal, and how do you decide that? It's a little off tangent, but it's related to the case. And again, do we use aminoglycosides in decomp cirrhotics? That's the other question.
So let me answer the first one. I think, this patient is on CVVH, so it's almost irrelevant in our hands. We adjust the dose for liposomal amphotericin. The second, amikacin and gentamicin. So we use boluses of gentamicin all the time as an SOS antibiotic, and it's very effective. Amikacin will do levels in order to decide the doses the next time. It's a very useful antibiotic, even in decompensated cirrhotics with ACLF, because the kidney is already gone here.
I mean, so that's a very surgical approach, because that's what we do we think that bolusing aminoglycoside is actually a good idea for very bad gram-negative sepsis. So we do use it in other surgical indications as well.
We have 4 minutes left and 2 people left to ask questions.
So we often get sensitivity to amikacin, but generally the trend is not to use it. So I mean, it's good to know that you can use it and get away with it.
Yeah, so we use it, but with our eyes open.
Hi, Kalyan, Cleveland Clinic. You said he had a stormy post-op course. I was wondering, did he have renal recovery or did he need a subsequent kidney transplant?
No, so he was fine, so he's now back to work, normal kidneys. He's had his reconstitution of his bowel.
Yeah.
And
this is a great story, yeah. Sometimes you actually
it's on Twitter.
need to look at...
This guy is really nice. He's a very big advocate for
it's
donation.
Age and fitness before transplantation, I think, was the key in this situation. 35,
Yes, right.
very fit man going into surgery.
Not sarcopenic and
Not
not like our
sarcopenic,
decompensated. Last question, please.
Yeah, Dr. Shiva Prasad, my question relates to the basic etiology of this case, as was already raised, that this is not true cirrhosis. So it comes back to, if you look at the canonic study and all the data from which you're extrapolating to apply to this case, how many patients actually had PSC in the original study? So which means how much can we really apply those figures to a case of PSC? And the point was also made that for transplantation, the etiology of PSC would probably tilt the balance in favor of liver transplantation, if it was rather than any other etiology of cirrhosis. So can we really extrapolate the results of this case to other etiologies of cirrhosis and ACLF?
That's a great question. So the first point about PSC, we know that his cirrhotic, his FibroScan is 50 plus, so very high, which is what we use in clinical practice. We know it's not true parenchymal cirrhosis as some of the other ones, but for all intents and purposes, cirrhosis, he's got portal hypertension, which is established with varices. As far as, and your second question was, can we extrapolate it to the other results? So we know that the results are almost as good, if not better, in alcoholic background. In NASH, it's the same. So etiology-wise, we have not seen any significant difference in overall outcomes in very large series of patients. But of course, the CHANCE study will give us a little bit more insight into that story.
Well, thank you so much on behalf of... is there another comment? You have a comment?
Please continue.
On behalf of the chairpersons and everyone on here, we thank Dr. Jalan and everyone for a wonderful presentation.